Okay. Welcome, ladies and gentlemen. I guess it's all gentlemen tonight. I seem to be the only lady here. I have Chris Oxford, Stetson Hobbs, and Thomas Payne so far for you, Dr. Frame.
Okay.
Folks, I'd like to introduce Dr. James Frame to you. He's your medical director for the EMT, AMT, and paramedic programs here. And the way that we normally work these is once I turn it over to Dr. Frame, with a small group like this, if you have a question and you'd like to speak up, just unmute your microphone and ask your questions, but then remute your microphone so the noise around you won't interrupt what everyone else is hearing. If you can't use your microphone, Chris, I don't see that you have one that's showing up on my screen. You can also move your cursor down to the bottom bar and there's a chat button that will bring up a chat box on the right. And I'm monitoring that, and I don't know if Dr. Frame's got that up on his screen or not, but I'll look at it occasionally to see if there are any questions there as well. Dr. Frame will stop intermittently and ask questions or ask you to chime in to make sure you're still there, because you do have to participate for credit if you're in the P2 course. If you're not in the P2 course, we welcome you anyway, and I hope you enjoy the lecture. So now I'm going to turn this over to Dr. Frame.
Well, I thank you very much, Jane. What I wanted to ask everybody is, we got Casey with us now. What I wanted to ask you is if any or all of you with me last month when we started the spinal injuries, if you just throw it into the chat box, just yes, I was with you, or no, I wasn't with you last month, so I know where to start.
Yeah, I don't think any of them were here last month that are in the current list, Dr. Frame.
All right, fair enough. Let me get that moved over there. And I got chat bar.
However, they can go back. I believe that lecture is posted, so after tonight they can go back into the MD Roundtable blog and find the lecture that you did last month and kind of back up and catch up if you'd like.
Well, if nobody was there last month, I can redo it. It's not a problem. Just make sure that next month when we have our next roundtable, that all you guys are there so that you'll be caught up with the previous group. If anybody misses this lecture this month that was present last month, then for the March lecture, we can roll right into the second half of this. What I want to do is introduce you to the topic of spinal injuries. Since we're in cycle 4, cycle 5 of the National Registry of EMT paramedic testing, spinal injuries are part of the trauma section, which is going to count for a full 30% of your exam. Medicine and trauma make up the biggest sections, followed by all the specialty areas, and don't forget EMS operations. We'll be having a lecture series on EMS operations probably sometime in April or May, depending on how we get through the next 2 trauma topics. One of the upcoming topics will be on EKG and myocardial infarction recognition. That promises always to be a good one because it's heavily tested on the National Registry. Now, let's face it, chest pain, shortness of breath, difficulty breathing. Those are all the big signs and symptoms of patients that have myocardial infarction. So it's going to be very important from a 12-lead standpoint that you recognize MI. We also have EMS operations, which makes up a separate and distinct section of the EMTP National Registry exam. And this one apparently has been giving students the most problems, more than any other section. I'm not just talking per-com students, but we're talking even the college students, Grayson College, Callan College, etc. If a person does fail the exam, they fail it because they missed a significant portion of EMS operations. So right now I'm in the process of identifying what the heavily tested topics are in EMS operations, and then I'll have a lecture that actually refocuses our efforts on the hot topics. And maybe we can narrow that spectrum down a little bit instead of trying to learn everything about fire department and EMS in one lecture. We can probably break that up over 3 lectures so that we cover it thoroughly, and yet at the same time narrow it to the topics that are being tested rather than everything. Because let's face it, after a couple of years on the street, you'll know EMS operations just because that's your everyday SOP. All right, so with that introduction, spinal injuries, 16% of the trauma topic, is something that's going to be tested for you on the exam, and it's pretty straightforward. Spinal injuries is not a hard section to pass as long as you keep your wits about you and think it through. Just from a statistic standpoint, you can see from the slide that I put up there right now that motor vehicle accidents constitute the largest percentage of spinal injuries. And that is a question on the National Registry. What's the most common mechanism of injury for spinal cord pathology? In this particular case, motor vehicle accidents, you'll find that a significant number of people, though, still from falls, for instance, people that fall down steps, fall off ladders, such like that, and then penetrating injuries, knives and gunshot wounds do that. And you'll see a relatively less number as a result of sports, football being big. Swimming is a big one, not so much the act of swimming, but the diving into a shallow area. If you think about it, when you strike your head on the bottom of the pool, you get that hyperflexion mechanism where your head snaps back because you struck your forehead, and that drives C5 right through the spinal cord, and paraplegia ensues. So there's a lot of mechanisms of injuries that are out there, but from a national...
I think we're having some volume problems with your mic, sir.
Mike, no.
It's cutting in and out.
Stand by, everybody, don't move. Okay, I'm going to have to do this without a headphones for a few minutes anyway. The statistic that I have down there, median age, 80% are males. That may or may not be tested. I've seen it on one of the previous cycles. And the median age at 38 years old, that's never tested. But just so you know, males around age 38, they're more subjected and more likely to suffer spinal cord injuries than any other group or class in that age 1 to age 44 age group, and then motor vehicle accidents being the most common. Okay, so we keep moving. These are fun statistics from a standpoint of knowing what a spinal cord injury costs this country, and not only that, but costs an individual. And it's not just economic costs, it's loss of life functions. It's loss of enjoyment. It's your basic ability to walk, talk, eat, sleep, go to the bathroom. Everything has to do, once that spinal cord gets injured, it's a devastating injury, probably one of the more devastating injuries that there is. Brain damage, brain injuries and such like that, very devastating as well. So the central nervous system, which is the brain and spinal cord, the central nervous system accounts for probably some of the highest disabilities and costs in this country as well. And it's amazing that a simple cervical collar or gentle handling of a patient, proper log rolls, proper movements of patients with suspected spinal cord injuries, a little bit of prevention in the beginning by very competent paramedics can save a patient a lifetime of misery, and of course their family. So when you look at research, that last statement down there, and I do want to make mention of that because I put it in there for a reason. It was on one of the National Registry exams recently. And now remember, there's 5 different variations of the test floating around. There's a 1,000-question bank. When you plug yourself into the exam and say, okay, I'm ready to take my exam, it randomly pulls down questions from all subject areas that are to be tested. Subsequently, in that 1,000-question test bank is a question that has to do with research in trauma, specifically for spinal cord injuries, and some of the strategies that we have as far as prevention of injuries and such like that. Something as simple as a helmet, shoulder belts, seat belts, not diving into shallow pools. Of course, don't play with guns. Don't get yourself in situations where there's gunplay. All these are strategies. They're actually, how do we as a society, and you can get philosophical for a second here, but how do we as a society, how do we address these issues? How do we put into place certain policy procedures, safety, equipment and such like that, that will eliminate or at least reduce the number of spinal cord injuries that are sustained out there? So you'll find that one of your EMS questions will have to do with research, and that research is focused on spinal cord injury strategies and prevention. Now, let's go into some basic anatomy right now. When you start from the base of the skull at C1, you go down to C7, that's all the cervical vertebrae. That's where all the nerves that come out of the neck that go down into the arms and upper part of the chest. And subsequently, an injury, the higher up you go on the spinal cord, the worse the injury is for the patient. So you can imagine that a C3, C4, C5 injury could be life-threatening. C1, C2 definitely life-threatening if they survive it at all. C6, C7 definitely quadriplegic type of stuff where they can maybe perhaps do a little bit with flexion and extension at the elbows and shoulders, but their hands are virtually useless when you get down to C7 and such like that, which are the nerves that get into the hands. As you get lower into the spinal cord, of course, the thoracic vertebrae, there's 12 of them. They mostly have nerves that go out into the chest wall itself. So when you take a deep breath, your whole chest is moving at the same time and in synchrony. And of course, the lumbar vertebrae, the same as the neck, the lumbar sends all the nerves down into the legs, pelvis area, genitalia, rectal areas, and such like that, all the way down into the toes. And subsequently, you can imagine that injuries at any particular level will give you a pretty specific type of syndrome or findings, signs and symptoms on examination, which will clue you in as to where the level of the injury has occurred. So when you look at a spinal vertebrae, you can pull it up on Google and such. But when you look at pictures of the vertebrae and such like that, you'll see the big front of it, the anterior part called the vertebral body. And then in between each vertebrae are these little cartilaginous pillows, these pillows made of cartilage, which are discs. And if you've known anybody that has had a slipped disc or a herniated disc where the disc slips out and touches a nerve going down to the leg, they got sciatica, they can have numbness, tingling, or weakness in that leg. Same thing with the arms. If there's a slipped disc in the cervical vertebrae, you can have quite a bit of difficulty with function in your hands and your arms. And then to keep the vertebrae stacked, imagine 2 real thick pieces of leather from the base of the skull, front of the neck, all the way down to the sacral area. There's 2 ligaments, curiously called anterior and posterior longitudinal ligaments, which keep the spinal cord and spinal canal, spinal bodies, if you will, the vertebrae, keep them all in line. Now, you still got some flexion extension. That's what a ligament does. It allows you to have some flexibility. But for the most part, they keep it aligned. So it takes a heck of a lot of force to actually shove a bone, fracture a bone, or to move a disc out of position where it impinges on nerves and such. But as is typical every day in this country, people manage to find a way to do it, whether by accident or intention. So understanding what the spinal column looks like and how it's designed will give you a better idea of what the risks are. when it comes to different mechanisms of injuries. For instance, the whiplash injury or the diving accident and its attendant injury to the cervical spine versus the gunshot or stabbing wound to the thoracic spine, or the fall from height or jumping from a height, and its attendant injuries to the lumbar spine. These are all very significant areas that you need to be familiar with. You don't need to memorize them. You don't need to know the actual dermatomes or actual, this nerve innervates this finger and this nerve moves this wrist and etc. But just a general idea that the neck moves the arms, the chest moves the chest and abdomen, and the lumbar spine moves the legs and pelvis. It gives you a pretty good idea that if a person can move their arms but can't move their legs, where their spinal cord injury is at, approximately. Now, the weight-bearing part of the spine, the vertebral bodies, the anterior part, the most forward parts that sit on top of each other with those cartilaginous pillows or those discs in between, that's where the weight bearing's at. So as you walk along, there's a certain amount of force always being exerted on the spinal column. So you can imagine if something heavy falls on your head, you can crush what they call axial compression, but you can crush down all the vertebral bodies. Obviously, that would be fatal to somebody, but any kind of jump where you jump on your feet and come down on your heels, or a jump from like a roof area or something like that into the ground, that force is distributed through the anterior bodies of the spinal cord, spinal canal, and the vertebral bodies. And you can get a fracture just about anywhere. So imagine if you weigh 200 pounds, you jump 10 foot off a roof, you hit the ground. The force comes through your heels, up through your femur, through your pelvis, into your spine. Okay, because there's no bone between the pelvis and the chest that's connected. The only place that's connected is the lumbar spine. So you hit there, you stop, but gravity is pulling your head, chest, and abdomen back down, and you'll find that in that type of mechanism of injury, the lumbar spine fractures very easily, especially at L1, L2. And so a person who has a fall from this height will have a lot of mid-back pain and such where L1 and L2 are at, perhaps T12, because that's where the forces come together. The sudden stop with the heels, but yet the continuing force of the head, neck, and chest against the vertebrae causes fractures of the lumbar spine. So as you can imagine, once again, if you understand forces and force vectors and directions that these forces go and such like that, a person who lands on their feet don't generally break their feet. They usually fracture their spine. Okay, so we know the spinal cord runs inside the spinal canal. And the spinal canal is formed by the bone that surrounds from the vertebral body around the spinal cord to the back to what they call spinous processes. That's where the left and the right side of the vertebral body come around to form a ring. And that's where the ring fuses together. So it looks like it's all one contiguous ring, just like a ring you wear on your hand. Subsequently, that ring that forms going down the middle of that ring is the spinal cord. And it starts, obviously, out of the brainstem, and it's a continuation all the way down to L1, L2. And then after that, the spinal cord breaks up into a probably 20, 25 spinal nerves that look like the end of a horse's tail, if you will. They're all kind of individualized nerves that are floating around in the spinal fluid. But the solid portion of the cord ends at L1, L2. Subsequently, we call it the cauda equina, the horse's tail. This is what usually gets impinged on when a disc slips in the back from trauma or from jumping or from just years and years of living. The disc all of a sudden slips, presses up against one of those nerves, and that's where you get pain going down into your legs. If that same disc up in the cervical spine had pushed against the spinal cord, you would get a whole lot more symptoms. Why? Because the cord is solid at the cervical spine, so pressing on the cord is pressing on a couple million nerves, whereas pressing on the free-floating nerves, the nerves float away a little bit or they don't compress as easily, and your symptoms tend to be a little bit more specific, more focused than it would be if there was a neck injury. Just for from an anatomy standpoint, sensory nerves, they go into the spinal cord through the back of it, and the motor nerves come out of the front of the spinal cord itself, and that's what controls our motor movement. So you can have a disruption of the posterior nerves, which will block all sensation and give you numbness and tingling, and yet your hands will still be moving around just fine. The converse is true as well. If you have a gunshot or a stabbing to the front part of the spinal cord, but the back part of the spinal cord is intact, then you may have numbness, tingling, or pain, but you can't move. And subsequently, there's different types of spinal cord syndromes that can occur, not only with trauma, but with different disease processes that can give you varying signs and symptoms of neurological deficits. We're not talking the same deficits as you would if there was a brain or a stroke, but similar. Okay, so the nerve roots pass out of the spinal canal and they go through the windows, the so-called foramen or the windows of the vertebrae, and they go out to the periphery, arms, legs, lateral chest walls and such. So just knowing the general direction, the posterior column carries sensory nerves, anterior column carries motor nerves, and you've just covered one more question in the National Registry. Okay, we call them dermatomes. So if my C5, which is back of your neck, just feeling your vertebrae back there in the lower part of your neck there, and you can imagine that a C5 nerve coming out comes all the way down, and it helps me move my shoulder and my upper arm. C6 will help me move my upper arm and my elbow, some forearm muscles. C7 helps me move my hands. C8 helps me move my fourth and fifth fingers. Now you may say, well, why C8 nerve if there's only 7 cervical vertebrae? And it's just the way that they're numbered. At the top of each vertebrae comes a nerve. And so C1 nerve comes out on the top of C1, C2 nerve comes out on the top of C2. When you get to the C8 nerve comes out at the bottom of the cervical, C7. And then it stays with normal numbering, T1, T2, T3, all the way down to L5, S1, S2, S3, S4. Those are all numbered properly, but the cervical spine has 8 cervical nerves, even though there's 7 cervical vertebrae. Is that on the exam? The answer is no. Is it something that's cool to know? Absolutely. Okay, so now we want to get into assessment. And the assessment of spinal cord injuries, it really has to do with how did you get here? What was the mechanism of injury? Now, I alluded to this a little bit earlier, and you're going to see this on a case scenario on the National Registry exam. It's going to give you a car accident where the person sustained whiplash and can't move their arms. It's going to give you a dive accident where the person dove into shallow water, hit their forehead against the bottom of the pool, snapped their head back, and the C5 vertebrae broke and drove the C5 spinous process directly into the spinal cord. And again, you're not going to be able to move the arms and legs. You're not going to have any sensation. Okay, they're going to give you a mechanism of injury, and you're going to have to know that whiplash injuries from diving or from motor vehicle accidents are going to be the more likely question when it involves cervical injuries. Gunshots and stabbings are more likely than not, if they injure the spinal cord, more likely than not going to be in the thoracic area, and a jump or a fall from height off a ladder, a construction site, etc., or jump off the roof is going to be mostly lumbar. Now, what happens if you fall down the stairs? Well, anything and everything can go. What if you fall from 20 feet or something? Well, again, anything or everything. But the National Registry is not interested in making things confusing. They put in 1 or 2 facts on each question that makes it so clear as to what the answer is that you can't debate it. So I'm just trying to give you a pattern of question that I want you to be aware of, in that the diving and the motor vehicle accidents account for more cervical injuries than anything else. Fall from height are going to account for most of the lumbar injuries, and that's just the spinal cord. Both got to go somewhere, and it's going to go through the spinal cord, but it's also going to go through. We're just talking. Okay, so we talk about who gets a cervical collar, who doesn't, who gets a backboard, and who doesn't. We're getting away from backboards. Why? Well, pressure points, risk of aspiration, can exacerbate some injuries and such. Okay, that's all well and good. So the person who goes off the road, goes down into a 15-foot ditch, crawls out of his car, crawls up the side of the ditch, and is standing on the roadway when you pull up, do they really need a cervical collar and backboard? No, because if they had something broken, they would have figured that out a long time ago. They'd still be in the damn car. So those people have already proved to you that they haven't broke their spinal cord anyway. They may have a broken bone somewhere, but at least everything's working and they had enough strength to pull themselves out. So in that particular case, you get on the scene, the police had already taken reports and such, then the patient says, oh, I'm complaining of a little neck pain. So then they call an ambulance. So you guys arrive on the scene. Well, the police are already done with their reports and such. Yeah, probably not. They don't need a cervical collar either. But for the patient who's unresponsive, or the patient who can't move in the car after being involved in the accident because he can't feel his feet or he can't feel his hands and such, the gunshot wound, these that have actual neurological deficits or complaints of loss of range of motion of their extremities, that these are very, very important. These people get log rolls, they get cervical collars, they get complete spinal precautions. Those are the ones that should be coming into me in the emergency department with a cervical collar, backboard, and full spinal immobilization, including all straps crisscross across the chest, one across the pelvis, one across the legs, to make sure that they don't move around on the board as well. And then, of course, safe transport to the hospital. So back again to the mechanism of injuries in the three areas: cervical, thoracic, and lumbar. Just know what the mechanism of injuries are more likely in these areas, and then who gets the spinal immobilization. You see both of them right there, right on this slide. Actual question. Spinal immobilization will be required for the following groups: A, B, C, and D, or A and B, or C and D, or E all by himself. Just know that there's only two: unconscious people, any patient with motion injuries. Okay. All right. If your person has what we call a distracting injury, it could very well mean that because of alcohol intoxication or because of a broken bone, you may not be able to pick up right away some of the other subtle symptoms of neurological deficits. So for instance, the person who does fall off a ladder from 12 foot, hits the ground, and is complaining of horrible, horrible pain to his leg because he broke both legs and both feet. He hit the concrete. And so you got a bone sticking out of the left leg, and you got a bleeding from the right foot because the calcaneus, the heel of the foot, is fractured and such. And this patient's in a genuine amount of pain. We get the patient into the emergency department, we take x-rays and such like that, and about 2 hours later, all of a sudden the patient says, hey, I can't feel anything in my legs anymore. As it turns out, we didn't CT scan the lumbar spine and pick up that there was a neurological deficit. That's what we call a distracting injury. The patient's so distracted by the painful injury of their legs that the subtle injuries of a neck or a thoracic or a back injury are missed by the paramedic, by the nurse, by the doctor. So it's important that not only the motion type injuries, but also anybody who's got altered mental status or distracting injuries, patients who can't communicate with you, patients where you ask them to squeeze your fingers and they can't do it very well. Yeah, I'm right-handed, but how come my right hand is weak? It's because they're developing some swelling to the spinal cord, and as the swelling continues, neurological deficits will progress, and they'll get worse and worse. So don't be fooled. These 7 items that I've listed for you here have appeared on the National Registry as be careful. These are warning flags, especially when your patient's alcohol intoxicated. And we all know that doesn't happen in Texas. So the problem is it does on a routine basis. A lot of patients come in intoxicated from an auto accident and you miss things. So most auto accidents involve an intoxicated patient where their intoxication is impairing their mental status. I'm not talking about the guy that's had 3 or 4 beers and may blow a .08. I'm talking about a person who's slurring their speech, altered mental status, just sustained a bad mechanism of injury, perhaps a bad accident, perhaps even an altercation. And subsequently, they can't tell you where they're feeling, where they're not feeling. Well, these patients do deserve a cervical collar, not always a spinal backboard, especially if they're walking, but at least a cervical collar. We don't have any heartache with cervical collars in intoxicated patients or patients that have distracting injuries. Case in point, just recently, we had a patient that fell off an adult horse, which is a good 7 or 8 foot fall. When you consider where your head is at sitting on top of the horse and then what happens when you hit the ground, it's about an 8 foot drop. And she had exactly that. She had an open femur fracture. When she came into us, she couldn't squeeze her hands any longer. It's because she had a spinal cord injury in the neck, and it was missed by the paramedics. Subsequently, she recovered, but the recovery period was months, where it should have been just days had a cervical collar been placed on the patient. And that's an example of a distracting injury. So don't you get distracted by their distraction. Okay, pressing forward. So we covered mechanism of injury ad nauseum. What are the disadvantages of immobilizing a patient on a long spine board? The big one, aspiration. Numero uno. Big one. Also, the second would be that it worsens the pain that the patient has because those boards are very uncomfortable. You want to experiment with something? Get a cervical collar backboard, full spinal mobilization, have your partners put you on a stretcher, and then let them drive around a city block. Let them open up the ambulance at 40, 50, 60 miles per hour, and you'll see how uncomfortable those boards can be. And then more importantly, you'll see what kind of anxiety it provokes in the patient who's traveling along on that board and collar. Okay, it's kind of a fun experiment. So let's talk about the big 5. And the big 5 is what I've got listed here. And if you memorize these big 5, you got yourself 2 of the National Registry questions. And high-speed motor vehicle accidents, numero uno, with 42% of all spinal cord injuries being suffered from motor vehicle crashes, you can imagine that the high-speed motor vehicle crashes, the higher the speed, the more likely the patient's going to suffer some sort of neurological deficit as a result of a spinal cord injury. Can somebody at 20 miles per hour get a spinal cord injury? Absolutely. I'm not saying it can't, but statistics show that the faster you go, the more likely the serious injuries or death. I mean, it's intuitive. It's not going to, this isn't brain surgery going on here. This is very, very intuitive, common sense, if you will. Subsequently, the motor vehicle accident isn't so much the speed as it is the sudden stop. Same thing with falls. The fall doesn't kill, it's the impact with the ground that kills. Again, the sudden deceleration is what hurts or kills patients. And so the faster you're going, the more force is moving forward, the bigger the force vectors are on the body when the body comes to a sudden stop. Falls from more than 3 times the patient's height. I'm 6'2", you get me up 18 feet, I'm going to have some sort of neurological deficit. There's just no doubt about it. a fall from that height is more likely than not going to injure the spinal cord than a fall from a lesser height. Now, could I take a dive off a ladder from 10 feet and kill myself? Absolutely, if I fall face first. But we're talking about a fall from more than three times the patient height where they impact their feet on the ground. They're going to have a crush injury to their back, which is going to impact their spinal cord. So in addition to motor vehicles, we got falls from 3 times their height. 3 times the height of the patient is a key rough formula that you'll see on the exam. Now, of course, you got blunt and penetrating trauma. You know, the knife and gun club is out there, and they're anything and everything goes with knife and gun club stuff. If it goes through T4 from a gunshot wound while a patient's lying down, they shoot them, they hit the shoulder, hit the neck and such, there's a good chance that bullet's going to go through the upper thoracic or lower cervical spine. Subsequently, you have to anticipate low blood pressure, low pulse rates, and altered mental statuses in these patients more likely to not have involved the spinal cord as well. And then sports injuries and other high impact situations such as high dives. You go down to Venezuela or Caracas or some of those other places, the Victoria Falls, where persons like to jump from 100 feet up and jump into the water. Well, they enter the water very carefully. You don't go in hands first, you don't go in head first, you go in feet first. And subsequently, if you don't have your toes pointed and hit that angle just right and have plenty of water that you can dive through without coming to a sudden stop on rocks or the bottom of the lake and such like that, those persons are high-risk activities. And those, again, when you fall from that height, when you hit water, it's like hitting concrete. So you save that for guys that have been doing it for a while. But again, it's a high impact situation. And then of course you hear about football injuries, hockey injuries and such like that, which can all portend to spinal cord injuries as well. Not only from the standpoint of getting struck specifically, but just having sudden deceleration forces acting on their spinal cord, acting on the spinal canal, which can result in a serious spinal cord injury. Okay, so your patient's standing on the side of the road after a motor vehicle accident, talking to you, alert and oriented ×4, no altered mental status, no intoxication, no distracting injuries, squeezes your hands, is able to walk back and forth without any kind of ataxia, in other words, unsteadiness on their feet, being unstable, favoring a broken hip or a broken leg, without any of that, and the patient looks perfectly neurologically intact, then no, we don't recommend that these patients be immobilized. As a matter of fact, they can come in non-emergent transport. They insist on being brought to the hospital. I wouldn't even put on lights and siren for those isolated types of patients. If you have any questions, pick up the phone and call. That's what we got base stations in the hospital for. That's why we have radios. That's why the radios and the phones are recorded, so that you call us, we tell you, yeah, you know what, based on your assessment, I don't see a need for immobilization. You want to play it safe, at least put on a cervical collar, that's fine. But, you know, use your discretion here. We don't automatically do like we did in the 70s, in the 80s, or even in the early 90s, before the trauma systems really started blowing up in this country, professing rapid transports and such. You know, not everybody has to be immobilized anymore. Not everybody. All right, this one's intuitive. I wouldn't put too much emphasis on this, except to say that the reason why I included this, now I remember why I included it, is that they're going to give you, they're going to say all the finer examples of mechanisms of injuries which could lend to spinal cord injuries and such, except, and it'll be one of these 3 that I copied off one of the questions. Dropping an object on a foot, twist an ankle while running, isolate soft tissue injury, You know, use your common sense here. But the high risk ones are the 7 that I mentioned earlier. Those are the big ones. You got to watch patients that may have spinal cord injuries as a result of one of those other 7. And in the introductory slides, the percentage of each one that occurs with motor vehicle crashes, falls, penetrating injuries, etc. But these 3 here would be examples of probably not. As a matter of fact, no way would you get a spinal cord injury from just something like this, unless you twisted your ankle while running off the top of a building or something. That's a problem. But when it's listed all by itself, these are pretty much the answers. Okay, let's say now that you pull up on the scene and you ask the patient, hey, what happened? They're like, I don't know. All I know is that 10, 15 minutes ago, I was in the house. Now I'm sitting out here on the driveway laying down, and it looks like my leg is fractured, and I've got this huge bump on my head. I have no clue what happened to me. Well, but a patient has a loss of consciousness as a result of a concussion, a strike to the head. One of the major signs is called retrograde amnesia. Not only do you not remember the incident or how you got there, but you can't remember for 10, 15, maybe 30 minutes before the accident. Retrograde, in other words, backwards in time. Retrograde amnesia. Yeah, I hurt myself at 11 o'clock according to witnesses, but the last time I looked at my watch that I can remember, it was 10:30. And all of a sudden I'm in the backyard on the sidewalk, wherever I'm at, or I'm in a car accident. Hell, I don't even remember leaving the house that morning. Okay, these are very, very, very concerning signs. So when a patient can't remember what happened, they've had a concussion, and if they can't remember because they've just been in a fall or a motor vehicle accident and such, guess what? We've got all the formula here for a spinal cord injury or perhaps even a serious brain injury. Okay. So we've got these uncertainties. As I said earlier, at 20 miles per hour, can you get a spinal cord injury? Absolutely. If you look over your left shoulder and you see a car coming and it hits you on the side here at 20 miles per hour, your head may have been just in the perfect spot to whiplash sideways and slide C5 on top of C6, and you severed your spinal cord. Freak accidents, dumb accidents, skiing accidents where they're not even going fast, where they hit a bump and then come down and they hit awkward on their back on some sort of little bump or something. All of a sudden T5 or T6 is shattered and the spinal cord severed. And yet, you know, unless you're a professional or Olympian skier, you're not doing 70 miles per hour. Most of the time, an average skier is doing 20, 25 miles per hour. What you would consider to be a low speed or a low to moderate speed accident in a car, it could mean a little bit of something for the skiers or for the bicycle accidents, the roller skaters, the snowboarders, and all the other activities that are going on out there. So tripping to the ground, falling, hitting your head, I don't know what to make of that. Falls from 2 to 4 feet or less than 3 times the height, not sure what to make of that. Fender benders, yeah, you know, I barely tapped them on the back of their, how many times have you seen that? Where the patient comes in, boy, my neck is really hurting. We barely dented your fender. Yeah, I know, but don't criticize these people. As a matter of fact, take them seriously because their head may have been positioned just right where that the force of even a minor fender bender put unnatural forces on the neck and may certainly have caused a spinal cord injury. Can you have a spinal cord injury without breaking your neck, without having a broken bone? Absolutely. We call it spinal cord injuries without radiographical evidence of injury. So, yeah, the bones look fine, but the spinal cord is injured. So we're concerned about all of that. Subsequently, immobilization is the best way to prevent further injury. All right, a couple more slides, and I think we'll wrap it up for the night. One of the premises of speech, one of the premises of lectures and such like that is to tell your audience what you're going to tell them, and then tell them what you just told them. And the reason why that I reinforce things, and it sounds like I'm going to stuff over and over again, is because if you're taking notes, I want you to say the thing at least 3 times. Those are the points of emphasis. Now, that doesn't mean that everything else in your book is not on the test. It just means that when I tell you 3 times about something that's going on with a spinal cord injury and how that injury came about or things to watch for on the test, it means that as one of the writers for the National Registry exams questions, that I've seen that topic come up in some form over the past couple of cycles. So it's worthwhile committing to memory, or at least understanding the concept. Okay. All right. Assessment of uncertain mechanism of injuries. All right, we're back to this guy again. The calm, cooperative, sober, alert, and oriented time. 4 patients. Okay, you could probably take his history as pretty much gold standard. Yeah, he's telling you what's wrong. Nobody intentionally wants to be paralyzed, so they're going to keep it quiet what they did. I mean, if they're hurt, they're going to tell you. But the patient who becomes a concern, not only from a medical standpoint, that, boy, does this guy have a spinal cord injury or not? I better be careful, because he falls into one of these 6 categories here. And when I say medical concern, it also means legal concern, because if you blow it, you're going to be doing landscaping the rest of your life, because there's not a state agency in the country that will take something where the mistake was so obvious, so patent, what you missed, that it borders on malpractice. So there's not only a medical concern for the patient's benefit, but there's a legal concern for your own benefit or for the people who hired you, whether it's a municipal fire department, whether it's a private EMS company, whether you're a paramedic inside of a hospital. All these people are responsible for your actions. And subsequently, they rely on your professional judgment and your experience and training to make the right call in the field. So knowing as a paramedic that you're out on the field and you run into an unreliable patient, and you'll see that in quotes on the National Registry, you have an unreliable patient. Okay, what does unreliable mean? It means exactly that. They're not too bright. They're altered in their mental status. They've had too much to drink. They're whacked out on meth, cocaine, heroin, whatever. They've got a distracting injury, or they have problems communicating, whether it's a foreign language or whether they've had a stroke and they cannot communicate, or whether they've had some sort of injury where it's affected their speech. It's not that it's a condescending term. It's not. It's a medical term of an unreliable history. In other words, you can't rely on what was said to you or what you had heard from other bystanders, because the patient doesn't have a mental status which portends to an accurate conveyance of what they're feeling at the time. Back to the distracting injury. I've got an open femur fracture. I don't know if my neck hurts or not. I really don't, because it hurts so bad in my leg, I can't get away from the pain. You could very well miss a neck injury. So something to consider. Same thing with the intoxicated patient, whether intoxicated from drugs or from alcohol, doesn't make a difference. The altered mental status is what's compelling here. Okay. All right. Now we're going to get into the general assessment of a spinal injury. We're just going to introduce the topic before we break away for the evening. But just know a couple things about it. When you whiplash, when you have your head spun, you see this on TV all the time, especially on the big action adventures where a secret spy, 007, or somebody that's skilled in martial arts will put their hands on a person's head and twist it violently, and the patient collapses and dies. Yeah, that actually happens. That's how you break somebody's neck and you kill them. That is one mechanism. Know that the adult skull weighs 20 pounds average. It's with the brain in it. So you're in an accident, your head goes forward, then it snaps back, or it snaps back and then it moves forward. where it moves forward while you're driving 70 miles per hour and you got a 20-pound object at 70 miles per hour. So that's about 1,400 pounds of force that's going against the steering wheel, against the windshield, etc. And subsequently, it only takes 1,200 pounds to break your face, to break the big maxilla bones here. So it doesn't take much. 70 miles per hour of a 20-pound object, and you've got what it takes to bust up the face pretty good. But the solid tissue that's up there in the brain has got about a 1/4 inch to a 1/2 inch leeway as it sloshes back and forth inside the skull because it's covered with fluid. So as you hit, your brain's still moving forward. It finally slams against the front of the skull, and as your head snaps back again, it hits the front of the skull again and goes the opposite way. You get this contra coup injury. And that's because you got a big old bowling ball sitting on top of a very skinny little neck, which then attaches to a very broad shoulders. And so you can imagine the head can snap around quite a bit, and that neck just doesn't take that much force. So any kind of rotational force, you're looking at the mechanism of injury now, but anything that has to do with a rotational force, such as being in a wrestling or being in boxing or worse yet, being in a street fight, or whether it's a motor vehicle accident, just know that that's a lot of force. And we're going to be looking at rotational injuries, compressive injuries, and of course the whiplash injuries. Now, the second vertebrae is designed in such a way it's got a little peg on top called the dens. And C1 sits on top of that ring with that dens sticking up through C1 ring, so that your head virtually stays on your spinal cord. So if the dens breaks off, your head can kind of slide back and forth a little bit further than usual. Of course, it's C1. If you sever the spine right there, that's it. Life's done. You're done. Because C1, C2 is where the heart impulses out of the brainstem come. The sympathetic chain and some of the other cranial nerves come out of this area as well, vagus nerve specifically. And as a result, breaking of the dens, the snapping off of the dens, that little peg can portend to some very, very serious, more often than not, fatal spinal cord injuries. So you get about a 180-degree turn from back to back. Now, if you're young, you could probably get to 180 degrees, shoulder to shoulder, touch your chin to each shoulder. That's about 180 degrees, plus or minus 10 degrees each side. It's not designed to go past that. If it does, you got some serious problems. More likely than not, spinal cord injuries, the least of your problems would be the muscle strain that comes with it, but just know that that's about the limit of the range of motion. And so, again, if you've got your head turned to the left shoulder or right shoulder, and all of a sudden you get hit with a force in the opposite direction, you could very well snap your neck right at that point. So, as the statistic down there shows you, cervical spine is particularly susceptible to injury, with about 1/3 of all injuries in the C1 to C2 region. Now, those are survivable injuries. You'll see that fatal injuries, invariably, almost 100% of spinal cord injuries that are fatal are at C1, C2. What is C2? C2 is easy. It's called a hangman's fracture. When you hang a person in a judicial execution, if you look back when hangings were the preferred method of execution, you drop the body 1 to 2 times their height, and the force of the noose snapping straight back, it drove C2 right through the spinal cord, and you were dead. It was instantaneous death. C2 is a hangman's fracture. So you can tell that the high spinal cord injuries are very, very serious. And persons who do survive C1, C2 spinal cord injuries, the Christopher Reeves of the world, they're on ventilators the rest of their life in a motorized wheelchair, and even with the millions and millions of dollars of medical care and such that Christopher Reeves could afford, he only lived 10 years after the injury. You can imagine somebody with lesser means, their life expectancy is 2.5 to 3.5 years, depending on whose study you read. It's just very devastating. And yet, a good C2 injury with a proper cervical collar applied, perfectly survivable. If they survive the accident, The cervical collar will make sure that they survive the rest of their lives and neurologically intact. That's why the cervical collars cannot be underemphasized. Okay, the last slide of the evening for general assessment. Next month we'll get into some more specific assessments, but general assessments of spinal injury. Posterior neck muscles allow up to 60 degrees of flexion forward, 70 degrees extension without stretching or movement of the spinal cord. Once you get past 70 degrees, when your head snaps back from that diving injury, or if you hit the steering wheel moving forward, if you're not restrained and your head snaps back more than 60 degrees, you do damage mostly to C4, C5 vertebrae, and that drives the fragments of the vertebral body back into the spinal cord, and you get paralysis. So knowing the mechanism of injuries, your takeaway for the first 20 slides tonight are going to be that the mechanism of injuries, the more frequent occurrences, what parts of the spinal cord are involved, and then what are the limits of rotation and such that the human body can from a parameter standpoint, can move. So 60 forward, 70 backwards, 180 each side, that's about it. When you exceed those limits, we start thinking about spinal cord injuries. Know about the mechanism of injuries and know about the causes of unreliable mechanisms of injuries and what you have to be careful of. Know the two groups when spinal immobilization is required, and then we'll pick it up next month. Does anybody have any questions before we break away for the evening?
Hey, Dr. Frame, I had to walk away for a few minutes. Did you see the questions in chat from Stetson Hobbs and Thomas Payne?
Yeah, see my chat.
That's okay, I got it up here. Stetson asks, if you have a calcaneus fracture and you expect lumbar back injury, what kind of spinal precautions would you take?
If they've got back pain as a result of a calcaneus fracture, then I would put them on a backboard.
Good answer. And Thomas says, is it common for a spinal injury to progress during an incident? Meaning if there was a distracting injury, would a medic discover a spinal injury during the secondary assessment?
More likely than not, they will, unless the patient's unreliable or they're altered in some manner. A proper exam of the spine involves pressing on each of the spines. Can you progress an injury? The answer is it depends. Mostly L1 fractures, L2 fractures, and such like that, it's never been reported where they've progressed an injury. Yet at C4, C5, they can progress an injury. And the reason being because of where the solid spinal cord is versus when it ends at L1, L2.
Gary Arbuckle asks, have you seen the new study that shows a soft collar is effective as a hard C collar, and do you think it would be something that has a place back in EMS?
You know, I'm not a big fan of soft collars. Patients get adventurous, if you will. They try to adjust their neck a little bit and such. Let's go back to the example I gave of the C2 Dens fracture. A hard collar is indicated. As a matter of fact, we sometimes build these halos on these patients and screw 4 screws into their skull so that they can't move their head at all. If the Dens is allowed to be immobilized for 8 weeks, you can take the halo off. The Dens will heal in place just like any other bone that's immobilized, and the patient get back to normal living. Yet any kind of movement that the soft collar allows, just even small, maybe millimeter movements, would impair healing of the Dens and could actually make a fracture where the bone has pushed up against the spinal cord worse as well. And when you're looking at the spinal cord and the cervical spine, millimeters is the standard. A 2 to 3 millimeter movement of the bone off the vertebrae into the spinal cord versus a 4 to 6 millimeter move is going to give you 4 times the spinal cord injury. And that's just doubling the distance from 2 to 4 millimeters. I mean, it's that small. So you can imagine when you take a breath, your head rocks between 4 and 10 millimeters, about 1/4 of an inch. Subsequently, we have to have that good of control on the patient's cervical spine. Subsequently, a soft collar does not achieve that the way that a Philadelphia collar or a hard plastic collar does. That's what we're striving to do. No mobility at all.
All right, Chris or Casey, neither one of you have piped up here. Have you got anything for Dr. Frame before he leaves? At least say he's typing something. Let's see, Casey, should hypotension be treated the same during neurogenic shock secondary to a spinal injury as hypovolemic patient or a patient with fluid loss?
Yes, as a matter of fact, it should. You need fluid boluses in these patients, and it's something that we're going to cover next month. And when it comes to treatment from a paramedic standpoint, once you get the patient log rolled and properly collared, you start an IV on them, and that's the next step that paramedics take now. If the patient's hypotensive, they're hypotensive because of neurogenic shock. They've lost innervation to their arteries and veins. The arteries and veins dilate, and as a result, blood pressure drops. So you need to give these patients fluid boluses to get them back up.
And last question, Chris Oxford asks, you arrive on scene, patient is pulseless with no breathing. The truck rolled several times. Patient's neck is at a 90-degree angle with stomach distension. Witness reports patient has stopped breathing 7 minutes prior to arrival. Would you C-collar this patient?
No, it's gone beyond, the head has gone beyond the 60 to 70 degree flexion. If they're at 90 degrees, they've stretched the spinal cord to the point where they've torn the spinal cord or they've severed the spinal cord. Certainly would explain why that they're breathing or their belly or guppy breathing, which causes the abdominal distension. But at that point, I wouldn't move the head because now we're going to have to get an MRI or a CT scan to find out exactly where the injury is at and how to reduce that cervical dislocation, those cervical fractures properly without causing more spinal cord injury. Although in the case that you described, I don't see that as a survival injury.
Sounds like a call from hell, doesn't it? Okay, well, we rapid extricated patient through the window since he was laying on the ceiling. We did compressions and transported. They worked it in the ER and called it.
Yeah, that's you made a valiant effort, and everybody deserves an effort because, like my grandmother said a long time ago when I was a kid, you're dead a long time, and so you make an effort. You make a good, valiant effort. Now, the fact that they've had this kind of injury at autopsy, it'll be shown that they died of a severed neck, severed spinal cord. At that point, there's it's nobody's fault. It's the fault of the accident. It was fate, whatever you want to call it. You didn't do anything right or wrong. As a general rule, I wouldn't be moving necks around, even if they're tilted. If you just kind of strap them down in place and move them the way that they are, try to be as careful as possible. But once you exceed the 60, 70 degrees, I don't see it as survivable.
All right, Dr. Frame, we know you need to go get some rest since you got another shift tomorrow and you're swinging back today. So thank you so much. Everybody, you did good. I've given you credit. So good night.
Those are good questions. My pleasure, guys. You take care.
Thank you. Good night.
Good night, everybody.